Thank you, everybody. I would like to thank the organizer of this meeting for inviting me to this beautiful Congress. It's really a pleasure. So I'm representing Africa. As you know, Africa is found between the West and the East, I can say, and my affiliation is to Addis Ababa University, Ethiopia. Okay, sorry. So outline of my presentation will be, I'll give you some background about Africa, the burden of CVD in Africa, challenges of CVD care in Africa, and response to this rising epidemics, and I will end with a conclusion. As you know, Africa it has this kind of map in total, but for UN grouping, it's classified into two because of economic and cultural difference. This part above the Sahara is called the northern part, which has a bit different cardiovascular profile, and the sub-Saharan Africa, which is the poorer part, and is a part of our interest today. So we will be focusing more on sub-Saharan Africa, and Africa in general has about 1.55 billion population with yearly growth rate of 2.3. And the median age is 19.3. As you can imagine this how much young population this continent is having, with a fertility rate of about 4. So you can also imagine how the growth is rapid. And based on the 2023 multidimensional poverty index, Africa has the poorest countries in the single continent. Of the 30 poorest countries in the world, 23 are found in Africa. And endemic diseases such as malaria, HIV/AIDS, and tuberculosis still persist. Non-communicable diseases related to these infections, and also rising urbanization has also grown fast. And when you see in the global context, globally, as you know, 19.8 million diseases occurred in 2022, and 30, this is amounts to 32% of global diseases. And 4 out of 5 of CVD diseases are attributed to ischemic heart disease and stroke. And the majority of these diseases, like the rule of 8, where 80% or 75% of these diseases occur in low and middle income countries. And when you see Africa in this context, CVDs are the leading cause of non-communicable disease and contribute substantially to premature disease. And of this, sub-Saharan Africa has highest share, and globally, Africa faces a double burden of disease, one from the infectious disease and the other from rising cardiovascular diseases. So when you see trends, as you know, the global burden of disease gives estimates of burden of disease at a certain time. From the 1990 to 1990 to 2019, the trend has increased in Africa. Though the age standardized mortality rate has reduced in most parts of the country, the decrement in Africa is not that prominent. So it's still having a very high prevalence. So what are the major risk factors driving these conditions? One is raised blood pressure. Okay, among the risk factors identified, hypertension plays a major role, though it is a major role in globally, but it has more role in African context. And the other is with the rise in urbanization, unhealthy diet and low physical exercise also contributes to this very high burden. And social determinants of health, like poor health financing and low awareness of health awareness of disease and low health seeking behavior, these all contributed to the high burden of cardiovascular disease in Africa. So if you see in groups, there are two types of cardiovascular disease, as you know, atherosclerotic and non-atherosclerotic cardiovascular disease. Non-atherosclerotic cardiovascular disease still have very high prevalence in Africa. To just see a few cardiovascular disease in the atherosclerotic group, ischemic heart disease is the one which is rising. The problem with ischemic heart disease is people have low awareness and they usually come very late when intervention is not possible or is not available. So this is one problem. And unlike other countries, ischemic heart disease like MI affects very young population. Like the average age for MI in developed country is 57 plus or minus 12, but in African context it is 52 plus or minus 12. Ischemic stroke is also very common, but the proportion of ischemic stroke is lower than the other countries because hemorrhagic stroke has very high share, like 50-50. But in other countries, it is 80% ischemic and more 20% hemorrhagic. And peripheral arterial disease is also something that's emerging. But this part of the cardiovascular disease is very important, like rheumatic heart disease, hypertensive heart disease, and different types of cardiomyopathy, of which dilated cardiomyopathy is the most common form of cardiovascular disease in Africa. Others to mention are congenital heart disease. Unoperated congenital heart disease is very common because there is no facility to do cardiac surgery in this setup. Corpulmonale related to indoor air pollution because this area is the ones where indoor domestic biomass is used for cooking. So this is related to corpulmonale. Tuberculosis is still common disease in this setup. So when you see some non-atherosclerotic disease like rheumatic heart disease, the prevalence is very high. It's among the very high region. It reached up to 1% of the population, and it causes significant morbidity and mortality. And globally, as you know, 41 or close to 41 million people are affected, and 23% of this is in sub-Saharan Africa, and about 400,000 diseases occur yearly due to rheumatic heart disease. And in Africa, specifically where I live in Ethiopia, it has got very malignant course. Children come early on, like at age of 10, 12, with severe valvular lesions. And the fact why this happen is not clear, but it may be related to poor health infrastructure. Because with that, there will be a very recurrent rheumatic fever. And the other is, it is also postulated that higher virulence of the bacterium, meaning the bacteria being more severe can contribute to the malignant course of rheumatic heart disease. The other condition which is more prevalent in African setup is hypertension and hypertensive heart disease. Globally, as you know, 1.4 billion, meaning around 33% of age between 30 to 79 are affected. And highest hypertension related dialysis are found in Africa. That means hypertension is more prevalent, more complicated in African setup. And 2/3 of adults in African setup have this high blood pressure. And since 1990, there is a greatest rise in hypertension prevalence across the world. If you compare with the global trends, like hypertension is controlled in only 23% of the cases globally, but this contrasts with 7% only in African setup. 44% are treated, while 27% are treated in African setup. 56% are aware of their disease in globally, but Africa, how far it is lower. It is only 80% who knows that they are hypertensive. It's a very frustrating figure. What are the challenges of CVD care in Africa? One is limited surveillance. We don't have data. There is no standardized surveillance of disease, so diseases are underreported or overestimated from the other countries. And there is shortage of health workforce. Diagnosis and essential medicines are not found in this setup. There is high out-of-pocket. Health financing is very poor, so people spend from their pocket to get services. If you see some of these factors, for example, to illustrate the low health coverage, in African setup, if you see this area, this is where I live, and this most of the areas do not have cardiac surgery, or if they have, it's only 0 to 0.1 per million people cardiac surgery. Cardiac surgery is found in only 0 to 0.1 per million. So this, you can imagine how low is the health workforce. This is just a reflection of the previous slide. High-income countries, for example, they have 7.15 cardiac surgeon per million, while in sub-Saharan Africa, it's only 0.12 million, 0.12 per million. This is very low. So what are the response to this rising burden in Africa? These are some of the summary of the response. The first is adoption of UN resolution. As you know, UN has enacted different resolutions since 2011, and the fourth one is a very recent one, and was in September 2025, where more rigorous involvement of the countries or policy in action is advised, and also depression is taken into one of the important part of NECDs. These countries have adopted this resolution. The other is task shifting and development of treatment protocols. Because the workforce is very low, the nurses and the lower health workers take the service of the doctors, and they manage people in the rural area. The other is implementation of WHO pain is package of essential NECD. WHO has released this package and more focuses on atherosclerotic type of cardiovascular disease. But other group of pain is called pain plus. It's rather including diseases which are not commonly mentioned in WHO or globally. These include rheumatic arthritis disease, type 1 diabetes mellitus, and air pollution related disease like corpus. So this is inclusive of this disease. The other establishment of cardiac centers in countries because of rising urbanization. There are interests from global side and also from wealthy people to start cardiac centers in this country. So this has been there. And regional and international collaboration, which we also share today, that's a BRICS collaboration is one of it. And different countries like China, India have supported different countries in Africa to start their cardiovascular services. Like China helping in doing submissions in Africa, donating equipment, and also building some institutions. India also offer low-cost, high-volume cardiac surgery training services, and India industries like pharmaceutical companies and also some interested individuals have started building cardiac centers in Ethiopia with a local team. And how can this type of collaboration mitigate this challenge? For example, the type of China support could help in donating equipment, in helping periodic missions, and also supporting maintenance of some donated equipment. Indian can, for example, help in providing consumables, lower cost devices, and with lower cost device and training that support sustained local services. And other countries like US and Europe have been coming to treat our patients and also skill transfer. And there is, even though the countries are poor, but there are emerging cities with kind of capable of paying for the service if it is available. So there is huge market in Africa for investors to come in, invest. And finally, I will conclude by saying this: health cannot be a question of income, but it is a fundamental human right, and everybody should aspire for that. This is by Nelson Mandela of South Africa. I thank you very much.